Hi, my name is Angelina, and today I will be giving a general overview of my internship. I had the opportunity to intern at a behavioral health organization under the Health and Human Services. I was able to join a team called the Health Home Team. The Health Home Team was designed to improve the mental health and physical health and substance usage of adults in the District of Columbia. And looking at the second slide, I talked about some of the problems that, um, or the reason why this program started. This program started because there was a high prevalence of mental health illnesses, poor physical health, and substance usage in the District of Columbia. And the leading factors that improved the rate of mental health illness and physical health was homelessness and low motivation and poor insight. A lot of the individuals in the District of Columbia do not have stable housing, which increase their substance usage and mental health illnesses and physical inactivity. According to research, about 18.1% of adults in the District of Columbia suffers from mental health illness. This might not sound big, but in a health perspective, it's still a large number. In that same way, 80% of adults in the District of Columbia do not engage in any physical activity. However, a lot of these individuals are diabetic and they have physical health problems that restrict them from working. A lot of them are undergoing pain management procedures, all of which has restricted them from being physically active. And because a lot of people are on the street and are homeless, there's a high prevalence of substance use. Now, when somebody is under the influence of a substance, it deteriorates their thinking and it causes them to engage in all sorts of activities that are not healthy for their well-being. In slide 3, I talk about the goals of the program. One of the goals of the Health Home program is to improve the mental health illnesses by improving the number of people that get screened for mental health disorder to 25%. A lot of the patients that I had the opportunity to work with did not know that they had a mental health disorder. Reason being that they were never screened for it. They never saw a psychologist. They never went through therapy. There's a whole chain that fits or that falls into the reason why they're having or experiencing some sort of disorder simply because they did not pay attention to it when it first came. So one of the goals is to improve or the number of people that get screened. That way they'll be treated at an early age to prevent any anything of being out of control, if so to speak. One of the goal of the program is also to increase the number of physical activities by 10%. Like I stated earlier, a lot of people in the District of Columbia are not physically fit. Some of them are due to an accident. Some of them are due to getting in a fight. The reasons as to why some of these people are not physically fit are all behavioral issues that can be modified. So our goal was to increase the physical activity by 10%. One of our other goals is to improve the overall physical, not physical, but clinical preventive services by 15%. A lot of, as I stated in slide 3, one of the reasons why people are using or substance dependent is because they don't know of the preventive services that are out there. Some of them do know it, but they're not utilizing it. That's all poor insight. So we want to increase the number of physical activity by 10%, the number of people that get screened by 25%, and then to improve the overall people that utilize health services by 15%. And how we're going to do that, we had some of the methods in place to help educate our population about ways to be physically active and ways to be mentally healthy and ways to decrease their substance use. And that was done through education. Under the education, we had care coordination, skill building activities, we have symptom management. That was for those that um, were taking some sort of medication to manage their pain, whether back pain, hip pain, any type of pain management. We also did healthy living education, but the big part of it was behavioral modification. Like I said, all these physical health and mental health disorders, as well as substance usage, were things that can be modified by simply adapting to a behavioral change. One of the methods that were implemented was linking the patients that were under my care or the care of the team in general to community resources, giving referrals and collaborating with healthcare providers to ensure that the patients were receiving the right form of treatment, which will in turn improve their physical well-being, mental well-being, and then their substance usage. In slide 5, I talked about, it shows a table of some of the results that were generated. Um, but in slide 7, you will see a breakdown of the evaluation that was done. There was an assessment that was done which asks a few questions. Have you smoked? Have you used substance in the last 60 days? Did you exercise in the last 60 days? Did you utilize health services? There was also a statistical testing that was done to see the prevalence and age of our population. There was also a program evaluation which was done to see the improvement of the program itself. But looking at the survey and the assessment, the results slide showed the number of people that smoked out of the 30 individual from my that were under my care. Now the program itself had a total of 90 people, but this result is showing only the 30 people that I had the chance to work with. Out of the 30 people, 6 of them, females, did not smoke. Now this result was done um, using measures that were talked about earlier. 6 of the females reported that they did not smoke. However, 16 females did smoke. In the same way, 4 of the male did not smoke and 4 of them did. Looking at the people that exercised, 3 females did exercise, 19 of them did not exercise. 1 of the male exercised, but 7 of them did not exercise. So looking at the individual report, one can conclude that the female adults were more receptive to the substance use activities far more than the male, as evident by the number of females that did not smoke. In that same way, looking at the second table, one can also conclude that the rate of adults or the number of adults who did not exercise was high among the females and the males as compared to the number of people who did not smoke. The other slide proceeding to the result also showed the number of females that utilize health services. 15 of them did use health services, 7 of them did not. In that same way, 7 of the male did use health services, but 1 of them did not. So the report showing above gives you a breakdown of how the people in our population are making use or understanding the program and the methods that were put in place. And the chart below that says behavioral analysis gives a breakdown of how or the percentage of where people are currently in the program. Now looking at the chart, 8% of adults in my focus group have not smoked. In that same way, 73% of them have exercised and 87 of them have utilized health services in the past 2 months. So this shows that the methods that were put in place are being effective and people are utilizing it, which is good because that's our overall goal, was to improve the physical well-being, the mental health well-being, and the substance usage of our population. There was also a program evaluation that was done by using structural process and an outcome evaluation. These evaluations were tailored to measure the condition and the capacity in which care was provided and how our patient felt about the services that were provided to them, which was good. The program is doing great on its own, but a lot can be done to improve the effectiveness of the program. One of the ways or the things, the strength of the program is the values of the program. And then there's also an active care coordinators and nurses that are working together to improve the well-being of these population that we are working with. However, we do have some weaknesses, which is there's not a lot of resources in the community that we can refer our patients to. We do have some resources available, but I feel like there's not enough. So that makes room for an improvement. But even with the improvement, there are some threats, which is dropout rates. So far, the people that we started with are still in the program, but just as any other health program, especially if the program is 6 months long, the chances are some patients might drop out before the 6 months is over, some might remain. So those are the threats and things that can happen. Now, the program is still undergoing. However, there are some recommendations that if it's being implemented, it will improve and cause the program to be more effective. One of them is establishing partnership with primary care physicians. As stated earlier, we do provide support for our patients to communicate effectively with their primary care providers, but there needs to be a partnership whereby primary care physicians are doing some health promotion during each visit. By this, I mean ensuring that they are talking to the patient about ways to improve their physical health, mental health, and substance usage. 100% of the time, doctors don't really have the time in their schedule to do education or health promotion. So one of the recommendations is to bridge the gap between physicians and our patient, and that can be done by forming a strong partnership with these physicians to ensure that they are educating, providing some sort of education to the patient during each visit. One of the other recommendation is to link patients to outside physician resources. The District of Columbia has a group of physicians that work awesomely with patients. However, because some of these patients are using Medicaid and are on different insurance, not all doctors do take the insurance. So if there's a link between patient and outside physicians, there will be it will improve the overall well-being of the patient because they will be able to go outside of the district to receive care from physicians, from specialists. Another way to strengthen the program is to improve the overall protocol for outreach. The program is doing great so far, like I stated earlier, but the current outreach that is in place is not as strong. It can be better, and it can be better by making sure that patients are engaged in the program. Patients feel connected to the program. Patients have ownership of the program. That way, it wouldn't be so hard on us trying to have people or promote the program to a state where the people will be engaged. The program and the results that will come out of the program will speak for itself. Now, outreach is good, and I think that if there's a more stronger outreach, it will improve the overall outcome of the program. But overall, it was a great opportunity. I had an awesome and great time being a part of it. I was able to utilize some of the things that I learned throughout the course of my MPH program in the at my internship site, and I'm really great that I was a part of the health home team and was able to make a change. There's a lot of improvement that has gone on, looking at the results that were generated, but I'm glad that I was a part of it, and I look forward into taking the things that I learned from this program to my future career.